Yeah, I did. I had some. It was, Sean. Yeah, good.
So we're gonna call this meeting of the Board of Directors of Woodby Health. The board values public's input and ideas and sets aside this time on the agenda to hear from the public on subjects of concern. We'll make every attempt for each person wishing to speak to be given an opportunity. All information will be taken under advisement. Generally, no action on your input will be taken during the board meeting, but to ensure proper response at a later date should it be needed. Please notify the moderator via a hand raise or chat function if you wish to speak, and limit your comments to 3 minutes. The board appreciates your input. Okay, we'll start with the consent agenda.
Motion to approve the consent agenda?
Second.
Is there any objection? Without objection is approved. We have any points of order? No points of order, we'll move on. Is there any public comments, John?
Not online. We've got some in the room that may wish.
My name is Judy Hupert. I'm from the League of Women Voters of Whidbey Island. I don't have a comment. I just wanted to introduce myself. We have a program called the Observer Corps where we assign members to observe the boards and commissions of local government agencies. So we can keep our members and the public informed about issues that they might be interested in or concerned about. So I've been attending most of the meetings on Zoom, but it's difficult, so I'm glad to be here in person.
Thank you. Welcome.
Thanks.
Thank you very much. We are glad to hear from you, and we are glad you're here.
Thank you.
I'd make a quick comment, and it's, I think I probably speak for at least 3 of us here, 2 ladies at the other end. You all did a really good job during the campaign and the election, et cetera, to get the word out and the opportunity to have a platform, which many of us don't have unless we've spent the kind of time. So good job, and we appreciate it.
Thank you. It's our most important thing we do.
Anybody else? John?
I have no one online.
Okay, we'll go to the medical staff report. Dr. Lenny.
Good afternoon. We have 2 main items, prevention report, and also we have a privilege request form for the hospital medical director physician designee. There's a requirement for the hospice medical director physician designee to have different requirements than the hospital medical director. There can only be one hospice medical director assigned at any particular time, which has a number of other requirements that the physician designee does not require. Now that Dr. Jerry Saunders is retiring, as we look for a new physician designee, this will make it more available to bring other physicians in that may not have all the requirements that Jerry's had in the past. So we put together the hospice medical director physician designee appointment requirements for that purpose. And we seek your approval.
Is there a motion?
I move that we approve the hospital designee.
I second.
Any discussion? Is there any objection? Without objections, approved.
Thank you. So,
Excuse me. Go ahead.
Dr. Lenny, I just have one question,
Mhm.
my own information. So will the new medical director be pulled from the current staff, medical staff?
so
Or,
the medical director is not changing.
oh, okay, the designee.
So the medical director is continuing, but since Jerry Saunders is the former medical director,
Mhm.
there wasn't a need to have any other kind of requirements because he already met the requirements for medical director. And so now that he's retiring, we need to make those distinct.
Okay,
And so as we bring in a medical director designee in, I don't know where they're gonna find that person yet. They're on a search. Very likely maybe someone from outside the facility. So for our credentials report, for initial appointments, Marie Glaze, MD, with Sound Physicians as a telehospitalist in telemedicine. Sean Dwagenda, MD, Skagit Radiology, Diagnostic Imaging as active staff. Melissa Gallons, MD, Physician Associates of Whidbey Island in Pediatrics is active staff. Bonnie Tolk, DO, in General Surgery is a per diem provider in active staff. Seth Kingery, MD, Sound Physicians is a locum hospitalist, courtesy staff. Kyung Byung Kwan, MD, Sound Physicians, locum hospitalist, courtesies. Megana Kinarawala, MD, Providence Telestroke Telemedicine. Amin Rabai, MD, Providence Telestroke Telemedicine. These are the initial appointments that we present.
Dr. Lemmy, what's wrong with hiring people with the name of Smith and White?
He doesn't mean that the way it sounded. but-
I know.
Are these all R1?
There is one R3. We actually raised the bar for what we require. R3 means that there's something that's out there, we're waiting to be resolved. When the credentials committee met on this and they presented to the MEC, this is something that is unresolved, but it's not going to affect their ability to practice. And so the MEC went ahead and approved them. There's one R2 as well, which has an issue in the past that's been closed. There's nothing that we're waiting on, and it's not considered significant enough to affect their ability to practice.
Okay.
Many times, these types of things are ones that maybe there was malpractice case or something, but it's been closed and finished and is done with. And that's what would be an R2. An R3 would be something that was perhaps their licensure is pending. They have a pending licensure thing or another case that hasn't completely closed out yet, that we're just waiting for the final information on.
And if there was a negative R3, they wouldn't even be on this list.
You wouldn't be on this list. If the MC had any significant questions about them, they would come to you, yeah.
The other thing about R3 is that where they're under proctor, so they're
Yes, that's
being
true.
evaluated by staff at all times as they're practicing, and then they'll get cleared beyond that in credentialing.
Right, exactly. Thank you.
Is there a motion?
Motion to approve the medical
Second.
appointment?
Second,
Is there objection or discussion? Hearing none, the motion is approved.
For advancements, we have Dean Levin, MD, OBGYN is active staff. Carly Bussey, MD, General Surgery Locum, courtesy. Spencer Schultz, MD, Orthopedic Surgery Locums is courtesy.
Is there a motion?
motion to approve. Second.
Any further discussion? Without objection, the motion is approved.
And for reappointments, Dan Fisher, MD, Internal Medicine, membership without privileges. He is a private physician who does not practice and see patients in the hospital, but he does refer to the hospital. Peter Sutcliffe, MD, Everett Clinic, Cardiology and Courtesy. Jeffrey Schoppel, RA, Scheduled Radiology, Diagnostic Imaging as active staff. Erica McDonald, CRNA, MSNA, Anesthesia as active staff. Sujata Angani, MD, Everett Clinic, Cardiology as courtesy staff. And Maria Restillo Restrepo, MD, Providence Telestroke and Telemedicine. These are the reappointments.
Quick question, what is the purpose for membership but without privileges?
I also have membership in the medical staff without privileges. I don't admit patients to this hospital. I don't see patients in any clinic of the hospital. And so I don't need to have privileges here in this hospital, but I practice in my own practice in town.
But you can refer that.
But I refer here and I'm a member of the medical staff.
And Dan Fisher's my doctor, so we know it must be good.
He must be. And he's my partner.
Any discussion? Without objection, or I'm sorry, we should make a motion.
Make a
first.
motion to approve the reappointments.
Okay,
Second.
now is there any discussion? Without objection, the motion is approved.
And that's the end of my report. Thank you.
Thank you, Dr. Lynn.
Can I ask a question? The orthopedic surgeon is local, is he working here now or gonna be working here? Spencer Schulte.
He fills in for us occasionally when we need coverage.
Health check report.
Thank you, John. I have two updates today. The first one is just to let everybody know that we are really highly focused, laser focused on revenue cycle at the moment. Patrick's been spending a lot of time working with Paul and Joy and Nathan, working through a number of different aspects related to processes, people, and it's an area where we just completely focused on right now to get improvement. Patrick's also been working with Paul on margin improvement areas, and we're making good progress there as well. The second area is an update on our enterprise data warehouse, which is basically our second most important technology project within health tech for this year. For those who don't know it, setting up an enterprise data warehouse for any company is really, looking at a cost of somewhere between, or starting at somewhere around $500,000 at least. So we're very, very happy that we're going to be able to put this technology piece together for all of our hospitals. The absolutely fantastic thing about it is that it's not going to cost any of our hospitals any money. So it's going to be a no fee situation for something that is a very, very high capital cost for an individual company or an individual hospital. And really with the view of, obviously getting all data into a single point, a single piece of truth, and most importantly, to be in a situation where one can make intelligent business decisions from the data. So we're very excited about that. We've made very good progress over the last few months. We plan to have our first demo to the CEOs and CFOs by March, the latter part of March. But we're extremely, extremely excited about this, and we think it's going to make a big difference for the hospital.
Thanks to Paul and the IT team here for working with us to provide the data feeds required to get that set up.
Thank you.
Dominic, the electronic data warehouse, EDW, are you insinuating that it's initially free or it's free forever? Or is there a?
No, it's going to be a free service to our hospitals. All hospitals that are under a health tech management contract, it's going to be free. Anybody outside of those contracts and the hospitals that we get new business from, it's definitely not going to be free.
Only other point I would make would be for Patrick and Paul, if you don't agree with me, you can throw something at him. A lot of times people don't hear about contractors, and what they do, but you've been to 3 meetings, I've been to 2 finance meetings with you, and I would just tell you, I'm totally impressed with your repertoire of understanding of the nature of finance and healthcare, et cetera. I mean, it's really, really, between that and Paul and Nathan with his background, it's going to be really helpful in the long run.
That's what I paid me for.
Thank you for saying that.
Yeah.
Appreciate it.
Very good, thank you. Okay, we will go to quality and compliance report. Sean.
Good afternoon, everyone. So for the board presentation today, just wanted to update a quick couple highlights for the team. Patient experience, outstanding HCAHPS inpatient survey scores for October. We'll review those shortly, but they were met or above national average in all but one category. So a lot of work on the inpatient team. Patient experience, so Shamik, our patient experience coordinator, creates and distributes provider awards for patient experience scores for 2023. So she's working on that, and she presents those to those providers individually in person. We hosted LifeNet Health Conscious Communication Seminar on site for various leaders of certain departments and understanding and describing how to listen, facilitating effective communication during stressful situations. It was a great communication seminar that was free from LifeNet Health for Whidbey Health. So looking at other options that they offer for us. Okay. So current accreditation licensure or notes of importance, we're still working on DNV preparation for our June 2024 survey. For Department of Health, we had a successful hospice survey last week, and the survey is every 3 years. There was no conditions or citations for any patient care components, and also we're awaiting that final report. Workplace violence events, we had 6 for January, 3 verbal, 2 physical, and 1 verbal physical with 2 staff injuries. We are on that journey of Meditech Expanse, so continuing for that 1 patient portal, 1 electronic health record. We're still in the build phase, and testing will be March through May, and then user training will occur in June with a go live date of July. Any questions?
Shannon, can you just give a little bit more information on the workplace violence,
Mhm.
you know, the basics of it, obviously?
Those are escalated patients that we're caring for in different areas throughout the organization at the hospital and the clinic.
Now, does that get reported outside of the hospital? I mean, do we report that to like the police department or sheriff or?
If that escalation occurs to that level, yes. And then we also partner with Washington State Hospital Association for de-escalation, and then Island County Public Health. We're on that coalition for workplace violence.
Can we just go back for a second?
Yes.
Maybe I didn't hear you correctly, so you might have to say it again. Did you say these were patient driven?
Correct.
So why do we? I'll just say it quickly, and not be instructive, but why are they called workplace violence? Because it makes it, to me, it makes it sound like that they were staff, you know, that somebody in the workplace was threatening somebody else perhaps, as opposed to it's a patient episode.
It could be either way.
Yeah.
At least in this case, we're patient events. We track all events regarding workplace violence, whether it's patients, staff, families, or visitors.
Okay.
But in this case, for that month, it was patients.
Yeah.
So yes, I see the breakout.
Mhm.
Great call. Mhm.
They add that qualifier to the,
We have it broken down even more.
And just for the public, this is a national problem on escalating violence in medical clinics and hospitals.
Thank you. Quality data updates for February. Infection prevention hosted University of Washington antimicrobial stewardship team on site, and that was during the medical staff meeting. They were very complimentary on Colleen's processes as an infection preventionist, and she is making slides so they could use them nationally on her processes for antimicrobial stewardship, as we've made significant changes. So that's a huge kudos to her and all of her work and partnering with all the providers. That is her focus, and many things, great things were said about her program. Education department upcoming TNCC classes with 5 students already expected. That's a larger class than normal, and implementation of additional training sessions on site by the education department. Trying to house that education on site as much as we can to accommodate our staff and providers.
this TNCC.
TNCC, I put the definitions at the bottom, trauma, nurse course.
Oh, yeah, I see that really
Yes,
clearly.
I know. Yeah.
We'll put it in the budget for bigger fun.
So medical staff credentials and NEC appointments are awaiting board approval, 8 initial and 9 reappointments. Currently credentialing applications in queue is 18, so the medical staff office is very busy with onboarding providers, so.
And Shannon, the TNCC course, it, correct me if I'm not right, is a lot, gives the nurses on the wards the opportunity to do a higher level of care for IV access and things like that.
Right.
And so it makes it more likely that patients can get that done more expeditiously without having to call anesthesia in to do things and,
As long as it's in their scope.
right.
Next slide. So HCAHPS we briefly talked about, but for October, you can see the very high scores. And then also we received the rating of at least 9 out of 10, 82% of the time. And national average was 70%, so we exceeded that. And then also definitely yes, 73%, and the national average was 69%. Just wanted to point out high scores also for the emergency department. The provider listened to what I said and was courteous when I was here. And then also I would recommend this facility to my family and friends, and that's on that 5-point scale. Patient experience trends would recommend or return the last 90 days, very high scores. And the walk-in clinics did see an increase of 0.02 since the previous report at the board meeting. Any questions? Thank you.
Thank you, Shannon, good job.
Nice.
Okay, Paul. Good afternoon.
I'll start with some highlights of our financial close for January 2024. We are reporting a total net surplus of $61,874. The budgeted loss was $228,821. Now, just to remind you, we have a budget for the entire year of a $214,000 profit. And the $228,000 loss for January is reflective of costs that we are incurring now relative to our electronic health record migration from Meditech to Meditech Expanse. And that will, we will go live with Meditech Expanse in July. So we're going to continue to incur costs of $150,000 to $250,000 per month for the next 6 months. So that was budgeted for. I'm very pleased to report that in spite of those costs and that budgeted loss, we are reporting a total net surplus of almost $62,000. So what drove that increase in earnings in comparison to budget was we were very busy at the hospital. Patient volumes were up over budget in virtually every area of the hospital and over prior year. So we're showing some very good year-over-year growth, and that growth translates to operating revenues that exceeded budget by almost $700,000. With that increase in revenue, we did see an increase in expenses, but they exceeded budget by only $366,000. And then on the non-operating revenue and expense side, we saw a favorable budget variance of $22,050. So bottom line wise, overall, a very good month. I've got some statistics down here, and you can see in those statistics that inpatient discharges, patient days, hospital only outpatient visits exceeded budget in prior year by large numbers. Same for surgeries, primary care, and specialty care visits. On the liquidity front, days cash on hand are concerning at 14.9 days, and net AR days, accounts receivable days, was 57.9, which is consistent with what we were seeing last month. John, if you'll take me to the next slide, we'll get into some of the details, and maybe you can make that a little bit bigger. We saw a slight decrease in our total assets from $116 million and change down to $115 million and change, driven largely by this depreciation expense that was incurred during the month of January. And that was about $600,000. So that really accounts for the drop in assets. And on the liability front, you see a decrease of about $700,000. Largely a function of paying down our current and our long-term debt liability. And then on the P&L below that, a little more granular representation of, the $61,000 net surplus versus budget at $228,000. And, again, the strong total operating revenues and, this increase in total expenses in comparison to budget. Any questions on those numbers before I move on?
I think I question your compensation level, given that you're called $830,000 change.
Noted.
No.
I won't make that mistake again.
Go ahead, get it in there, buddy.
Yeah, take us on to the next slide, if you would, please. We've spoken briefly about those volume changes there, and maybe, okay, no, that's fine, because the year-to-date column is the same as the current month. This is a statement of cash flows, where did the money come from and where did it go? And you see from net cash provided by operating activities was a decrease in cash of $1,663,000. And that was largely a function of paying down accounts payable, $1.4 million, paying down other current liabilities, $266,000. We did see an increase in accounts receivable of $835,000, which impacted us negatively. We incurred some expenses that were classified as prepaids, $448,000. So on the operating expense side of our business, or on the operating cash flow side of our business, we saw a use of cash of $1,663,000. We did incur a reduction in cash relative to the purchase of property, plant, and equipment, $345,000. And below that, you see cash flows from financing activities. And what that is repayment of debt, bond and capital lease debt. So we saw for the month a decrease in cash of $2.571 million, which leaves us at the end of the month with $5.342 million in cash. On the next page, you're going to see a cash flow forecast. So what we just saw was where the money went last month and where it came from. And what you're seeing here is a projection of where our cash is going to be after these cash receipts by week and cash disbursements by week. And John, if you go down near the bottom, you'll see a day's cash on hand right here. And we're sitting at 12 today. And if you go out to the far right, 26 weeks from now, we'll be at 12 days cash on hand. So we are weathering the storm. We have added staff in our patient financial services areas where we've had vacancies. And we've added four staff members in the last 60 days. And sadly, they're not experienced, so we're having to train them up. But we're almost at a point where we can handle the daily throughput, and we've engaged a contractor or contractors to work the old accounts to keep that cash moving and coming in. Dom mentioned a margin improvement plan that Nathan and Patrick and I have spent a little time on. And we are expecting to see a little better than $3 million in expense reductions over the remainder of this year. So cash is front of mind with me and everyone on the leadership staff, including health tech.
If you flip to the next month, obviously, we've got a big dip from 12 to 12 and some certain days in between.
Right.
How's March and April look in your opinion?
April is, we're looking forward to April. April is a month when the levy receipts begin to come in. And May is even better. So we're just gonna have to manage our costs very tightly and continue to build a foundation in patient financial services to improve our billing and collections, reduce bad debt, bring in cash earlier rather than later.
Are there any forecast purchases that could be pushed off for 2 to 3 months? Or
We are looking at everything we're buying with that in mind.
And John, it's kind of interesting, you're saying that you have people that need training.
Mhm.
The good part is they need training and you don't hear, why are we doing that? We've always done it this way. You know, it's kind of nice that you're breaking that cycle.
Yes.
We've always done it this way. Why are they trying to change it? Well, this way hasn't worked,
Right.
you know, and so I think you're doing a good thing on bringing in people that you're training that are gonna do it your way.
Exactly.
Well, there's a lot of competition out there for the kinds of people that are needed in terms of revenue cycle and accounting.
Yeah.
And that's a tough slug, getting some of those positions filled.
It is.
Sure
And
it is.
there's numerous applicants for those jobs. Very few of them have any experience that's pertinent to that line of work.
So the public, what the public can do is use Whidbey Health for their healthcare.
I'm sorry.
The public should use Whidbey Health for their healthcare to
Yes.
support their community hospital.
Absolutely.
Okay,
Good message.
that's what we want.
Thank you for that.
Any more-
Anything else?
Any more discussion?
Well, just add to that, despite all the things that have gone on in the last several years, but that this helped prior to the last 2 years. The quality of care at Whidbey Health has never suffered. And we've kept an eye on that. It's the patient perception and the patient's experience that, suffered as far as, some individuals who were not as customer friendly in that sense, and the financial men. But the quality of care has always been good.
Thank you, Paul. Good job.
Yes, sir. Thank you.
All right, Tim, you are up for IT report, facilities report.
Yes, thank you. If I haven't given a report in a while, they can give my report, so if you hear anything you've heard in the past, I apologize for that, but IT, obviously, Shannon kind of gave an update of where we are with Militech Expanse. That's the main focus, obviously, for IT and a lot of the organization. We are in the build, things are going well. We're starting some training and rebuilding the systems and making processes better, so it's going well. Facilities, as everyone knows, we purchased a building and we made it our new women's care. Facilities did a lot of work and IT to get that building ready and up to date and in a situation to provide great patient care. I know the staff loves it, so it's very sharp if you have it in that building. So a lot of work is done with facilities to get that done. VI, where we're at with that project, our new CP is up and running. There are a few calibration issues at first, but there's been pretty trouble since that was corrected. The new X-ray was delivered, but right now we are working with Siemens. We are at a standstill. They dropped the ball in getting us the table with the new X-ray. Their resolution to this situation is they're going to remove the X-ray, give us a new X-ray with the table, and this will occur. That we held them down to a timeline of May. So once that is completed, then we can move forward with the rest of the project, which is remove the old X-ray and start the remodel of the room to get floral up and running, so. Getting close, but it's gonna be delayed till probably July before that floral is up and running. DOH has approved most of the project, so, it's just that one room that is left. Lots of work going on in other parts of the organization, we're continuing to pick away at the ER, do some updates in there, we're stripping the floors, trying to get walls painted and spruce it up the best we can, with, the space that is there. We're doing some work down on materials right now to redo some spaces for new employees that they're adding to the materials department. So lots of things going on. We're doing a lot with this building that we're in, the newer building. We have some lighting issues and some heating and cooling issues, so we have a lot of work going on with that to try to get those issues resolved. Other than that,
Is that what they're doing on the roof across?
that is our lease that we had sold a while back, but that is AT&T updating their cell towers. If there's any other questions about anything, I'll be glad to answer.
AT&T pays us money to use their.
They used to, but we sold that lease, we got $800,000. Which was the right thing to do because they were paying us very little, so if anything gets added, we can see added returns on that in the future.
Thank you, Tim. Good job. Okay, next we will have operations, outpatient services, nursing report, human resources, and administrators report. Nathan.
Our sort of operations, going through Garth notes here, we have 44 full or part-time employee providers in Whitby Health, 14 primary care, 10 walk-in clinic, and 20 specialists. We also have an additional 11 per diem providers, with a total of 55 employee providers. And 26 of those have been recruited in the last 2 years. And we also have quite a few still under negotiations and working on those. So even with all these, we're still hearing that new patients are waiting 2 to 3 months for primary care appointments. So that's our big focus, to try to find more primary care providers. It's kind of twofold. And I think one of the things, if you look at our outpatient volumes, we're getting busier and there's still a wait. So that means people are starting to utilize our services. All our outpatient volumes, as you saw in Paul's report, going up. We have a new provider starting at Cabot. He'll start in April. We're interviewing another physician for Freeland, I think next week. Have a new provider starting in March at Oak Harbor Walk-in Clinic. Jeff Carroll came back and will be starting with us, actually has started with us now back in Clinton. And we have a new nurse practitioner just started a couple of weeks ago at the Coopville Walk-in in primary care, and we have another physician starting in April in walk-in. So hopefully by the end of April, we'll be able to expand to at least 5 or 6 days a week for walk-in and primary care. Dr. Tulk, as you saw earlier, started this week as a per diem general surgeon, and we're talking to her about hopefully becoming full-time this summer when she gets out of the military.
Nathan, question.
Yeah.
Oh,
I'm sorry.
no, that's okay. I was curious, I know that quite a few students go through the hospital. And so, what is the sort of speculation about how many of those students then either choose to come back and practice here or?
So most of our physician or provider students are go through the hospitals as the rotation. And so Rosa kind of gets to pick and choose. We do have 2 I know that we're talking to that are interested in coming back. Most of those aren't interested in the primary care, which is kind of right. We are getting a lot of applications. So, yeah, exciting to have all that. We also have 2 orthopedic doctors that will be joining us. One will be, I think in August, just when he gets out of the Navy, and we're talking to another one that will be a part-time. But they are going to start doing cases here for the Navy. We've reached an agreement with them to start doing some of those cases here. We have a new OBGYN physician starting in April. And
That makes how many now?
it'll be 3 because we're losing 1. Okay. Behavioral health, we have a new one starting in September, so that will make our 3rd.
A physician?
Nurse practitioner. And then, that's really about it for that. Expanding some things in pharmacy. Rehab is growing considerably as far as patient volumes. We do have several contract labor people in there that we're trying to replace, but the volume is there. We're actually looking at resuming our services back at Goldie in Carver. And then Meditech we've heard about. That's really about it for operations. Don't have anything on nursing.
Can I ask you a question?
Sure, absolutely.
Obviously behavioral health's a big issue, big challenge, and lots going on here. I heard from two people that found they were completely unable to find a psychiatrist for an evaluation, possibly around some form of autism, et cetera. Any consideration around
If we
a
could-
psychiatrist, or is, I mean, obviously
Yeah.
difficult, I'm not.
Yeah, extremely difficult
Yes.
across the country. So we, you know, as we have this behavioral health, anything we get, we look at. We have not had, to my knowledge, a psychiatrist apply for anything yet. So that's an ongoing challenge, which affects the ER.
Nice thing is the psychiatric nurse practitioners can fill pretty much most of the role that a psychiatrist will. Maybe not as in depth, but from probably I would say 80–90% of the things that a psychiatrist would do, a psychiatric nurse practitioner can manage on an ongoing basis.
I don't have any updates from human resources right now. They're knee deep in several projects. Just as far as administrators report, you heard a lot of things from Paul. One of the things that we're really focusing on is some of our processes. There's been a lot of quick fixes and Band-Aids put in place over the last few years that are, in my opinion, making things more difficult than they have to be. So we are going to be focused on that, especially me looking at processes and how we improve those. So there'll be a lot of change upcoming. But I think it will make us much more productive and get things done well. That's pretty much all I have. Unless you have more questions.
Questions, issues? Thank you.
Sure.
All right, let's move into general board items. We're gonna have a legislative update from Marion.
Yes, we are. So, that's where she wrote that down. Well, the latest from Washington State Hospital Association on their current bills that are out there. There's several that affect would-be health, and one of them was credentialing for EMTs and paramedics to be medical assistants within the emergency room. So they're looking at being able to credential them, and then they could come in and work in the ED only to the extent of a medical assistant. So that would be their scope of care, and that would expand the workforce in emergency rooms. We would, hospitals would be able to pay them to come in and do that, and that would help some of the people in our community who are EMTs and need some extra work if the bill passes. And it's very optimistic. There's a budget item for rural labor and delivery hospitals. Many in the country have smaller volumes of patients, under 800 deliveries a year, and you need to maintain your staff. So they're looking at adding into the budget about $400,000 per hospital to help them maintain staff during the lulls of admissions. But we'll see how that goes because it's in the budget process, and there's a lot of demands in the state. And those were about the main ones that were affecting us right now.
Any questions? Thank you, Marion. We appreciate you. Actually, now I want to recognize Greg because Greg's been doing an outstanding job working on the strategic plan. Would you like to give a little bit of update on how you're doing?
Sure. I don't know about outstanding, if everybody will prove that at the end. I do know that we still have 9 members of the Executive Management Council that are still alive and well, so they've withstood the test of time. So far, what we've done is really looked at the previous work that was done, how it might be integrated. We've developed a very fine draft mission statement that we look at each time, vision statement, set of 8 core values that would be very, very important with descriptors. We're starting to look at focus areas and developing goals with specific objectives to achieve those goals, action items, if you will. Followed by strategies, the methodology, how to do that based on the guidance that's going to be given to the person that would own one of those goals. There'll be approximately 15. Those people will be called goaltenders, and they will have outcomes and deliverables that will be assigned over a period of 1 to 3 years, which will be prioritized based on available resources, budgetary times, et cetera. And then each one of the goals will be listed under a champion, and that champion will be on the EMC. That champion will run interference, make sure that the guidance is clear, ensure that the appropriate resources and tools are available, and that the progress is being made. So basically a lot of good work. The last thing we did was to evaluate the stakeholders, which in essence were a list of entities, people, socioeconomic groups that have a stake in Whidbey Health doing well. Obviously, we're the biggest employer on the island, and far more entities have a stake than we realize in terms of EMS, taxpayers, so it's not just patient and visitors, and that's very helpful in establishing the goals, foundation, charitable organizations, et cetera. So we've got, we're a little bit more than halfway, and if they don't quit, so
We don't.
yeah, that's right. So I'd say, we have another roughly 6 weeks and we'll be done. And then we'll be able to brief it and take our spears and arrows. So, right, Sam, anything else you guys want to throw out there? These are some of the survivors. Thanks.
Well, it's looking really good. Compliments, I think it's a great effort, and I think it's gonna have a good result.
Yeah, no, everybody's working hard and they're pitching in and the ideas are flowing, so it's all good.
Okay, Samar, did you want to add something to the board?
No, just as a participant today, but yeah, very briefly that the last 2 months we were prioritizing a lot hiring and restructuring within the foundation. So I can say year 2023 was a hamster on the wheel year, and now 2024 is more of the restructuring. The first quarter, second quarter, we're focusing more on internal restructuring, building the team, and the strategic plan as well. And then we'll start seeing the return on investment on third quarter and fourth quarter. I'd like to mention that we've already hired the fundraising and development specialist. She started this week, and she's in the office right now. And then in 2 weeks, will be joining us 2 more team members. One as the foundation coordinator and another as the grants and philanthropy programs coordinator. Thank you.
That's great.
Thank you, Samar. Okay, it's become necessary for us to change our procurement policy.
We are gonna table that until next month, Mr. Golder. There's some other changes that need to be addressed and represented to the finance committee next month.
Okay, very good. Very good. At this time, we will go into executive session. We will be taking no votes and making no decisions. We have 2 items on our agenda. One is the dealings of real estate. And another one that's been added is personnel discussions. So as far as time is concerned, we say an hour and 15 minutes. So we'll take an hour and 15 minutes, which will put us back here at what time, John? 2:05? 2:05. Very good. So at this point, we'll adjourn into executive session until 2:05.
Who do you want to stay here for your birthday?
That would be Tim and Ben. Okay, we'll reconvene our board meeting for Whidbey Health. We have executive session. We had no votes. And no Well, we just had no votes. We will not be picking up any more information on the real estate purchase because apparently there's still some discussions that have to be made, so we're gonna put that off until a future time. At this point, we'll go into commissioner comments. Greg, would you like to start?
I would, just by saying that, to Paul mostly, and Nathan. We're at a really big point in time, you know, that I wasn't expecting to be in terms of the finances. And that's actually in recognition of how well you've dug into the things that were not appropriately accounted for in the past, you know, and then recognized in the amount of money that you've taken out to pay down the debt and the AP that we have, which is a slippery slope. And I know a number of organizations that defer that debt, thinking that they're gonna rob Peter to pay Paul, and ultimately it's worse and worse. So I know it makes you, I can see it on your face, Paul, that this is a big burden to you, and I really applaud you for the strength to take the burden of the weight of that. And I think that in 2 months, we'll be looking at a different picture. And again, for you, Nathan, it's just so critical what you're doing to look at where can we cut some expenses, you know? And yes, maybe 50,000 here, 50, you know, pretty soon that adds up to what you call some chump change. You know, pretty soon it's 800,000. And so those are real numbers. So anyway, don't want to be long-winded, but I applaud you for what you're doing. I recognize how difficult it must be. And I know in a couple months, you'll get the smiles back on your face that you used to have. Okay, and we're behind you.
Thank you.
That's my comment.
Well, my comment would be, I can't wait till you're done cleaning up the issues from previous things so that we can hold you accountable. Yeah.
That'll be in the next strategic.
Yeah, so I'm waiting for that date. And, you know, the other comment I'd like to make is that, you know, Nathan, I'm just really impressed with the admin staff that you have up there. I mean, you know, all of them, you know, I don't care. You know, it's amazing that where we're at, I see the reactions of the people on the floor and other places that they're enjoying working here. They have smiles on their face. I think we're going in the right direction. And just encourage you guys to keep it up and, you know, get us to that place that we want to get. But like I said, it's just encouraging when every one of the departments, you know, when they come in and we talk to them. It's just getting, you know, got really good feelings on where we're at.
Thank you. More of the same, you know, of what these two gentlemen said, but on top of that, I'd like to say that it's very exciting to see the metrics for satisfaction, patient satisfaction. And even some of the tiny things, like when Tim was talking about facilities, things that we may view as tiny, like in the ER starting to work on the floors, a little bit of paint here and there. I think that goes a really long way in the community, because that's what affects them. You know, they take their family member to the ER and it's like, oh my gosh, I'm sitting in here just looking at all this. So I appreciate that that's part of our report, that we get to hear about these things. Thank you.
Yeah, well, I watch the social media on the south end and there's, you know, 10, 12 great, someone makes a comment and there's 10 or 12 great comments and then maybe one of the old, you know, 10 years ago, happened.
Yeah.
And so that's really a sea change. And so that's reflective of all your hard work and then every single person in the hospital's hard work to do, and clinics to do great patient care. So thank you very much. And I just want to say that next month, we'll be reviewing the bylaws and the code of ethics so that it's done.
Thank you. Okay, the next board meeting will be Thursday, March 21st at 12 o'clock. If there's no other business. No objection.
Adjourned.
Adjourned.
Thank you. Well, that's pretty-